This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending in spine surgery.
And I'm Dr. Alara, a research fellow. Today we're looking at a fascinating new study from the journal Orthopaedic Surgery, published in 2026. It's titled Single-Segment Spinal Decompression and Fusion with Selective Nerve Root Block in Adult Degenerative Scoliosis, a retrospective comparative study.
This is a paper that hits home for many of us in the OR. We're dealing with adult degenerative scoliosis, or ADS, a condition that really characterizes the challenges of our aging population. As the authors point out, these patients usually manifest symptoms around their 5th or 6th decade. They come to us with back pain, radiculopathy, and neurogenic claudication.
Right, and the pathology is driven by asymmetric intervertebral disc degeneration, facet arthropathy, and ligamentous laxity. The therapeutic dilemma, as the authors call it, is whether we should go big with a long segment fusion to restore spinal equilibrium or try to limit the morbidity by staying short.
Exactly. The traditional approach is that long segment posterior lumbar interbody fusion, or PLIF, is the way to achieve complete neural decompression and restore sagittal and coronal balance. But we know the cost: iatrogenic paraspinal muscle injury, significant blood loss, and a longer recovery. This paper asks a provocative question: can we use selective nerve root block, or SNRB, to pinpoint the one responsible segment and just fuse that?
It's a compelling concept. Let's look at how they structured the study. This was a retrospective cohort study conducted between July 2019 and December 2021. They looked at 87 patients. 32 were in the limited group, single-segment PLIF with SNRB, and 55 were in the long-segment group, which they defined as 3 or more segments.
Now, before our residents get too excited and start doing single-level fusions on every deformity patient, we need to look at the inclusion and exclusion criteria. This is where the selective part of the study really matters. Alara, what were the boundaries here?
Very important point, Dr. Aris. All patients had to have a Cobb angle greater than 10 degrees. However, they specifically excluded patients with severe sagittal imbalance. If a patient had a sagittal vertical axis, or SVA, greater than 50 millimeters, or a pelvic incidence minus lumbar lordosis, or PILL gap, greater than 10 degrees, they were out. They also excluded severe osteoporosis, meaning a T-score less than -3.5.
So these are patients with ADS, but their global alignment isn't completely off the cliff yet. They are symptomatic, but perhaps their pain is driven more by a specific neural compression than by the overall deformity.
Exactly. And the secret sauce in this study was the SNRB. The authors used it as a diagnostic tool. Under imaging guidance, fluoroscopy or CT, they targeted the suspected pathological nerve root. If the patient had a positive response to the block, that segment was identified as the surgical target. This allowed for a focused surgery, avoiding extended decompression and fusion.
Let's dive into the results. What did the data show when they compared the single-segment group to the long-segment group?
The most immediate differences were in the perioperative metrics. The single-segment group had a significantly shorter hospital stay. That was a p-value of less than 0.01. But perhaps more interesting for surgeons, the revision surgery rate was significantly lower in the single-segment group.
That revision rate is a major talking point. In long-segment deformity surgery, we often worry about proximal junctional kyphosis or hardware failure. By limiting the fusion, they seemingly mitigated some of that risk. But what about the clinical outcomes? Did the less is more approach actually help the patient's pain?
They used 3 main metrics: the Oswestry Disability Index, or ODI, the Visual Analog Scale for leg and back pain, and the SF-12 for quality of life. At the 6-month follow-up, the single-segment group actually showed better improvements in ODI and SF-12 scores.
Better at 6 months. That likely speaks to the accelerated postoperative mobilization the authors mentioned. Less muscle trauma and a smaller surgical footprint means these elderly patients get back on their feet faster.
Precisely. However, by the final follow-up, which was at least 2 years, there were no significant differences in clinical outcomes between the two groups. Both groups achieved equivalent efficacy in terms of pain relief and functional improvement.
That's a crucial finding. If I can give my patient the same outcome at 2 years with a 1-level fusion and a shorter hospital stay, why would I do a 5-level fusion? But we have to talk about the trade-offs. What happened to the radiographic parameters in the single-segment group?
That's the inherent limitation the study highlights. While the long segment group provided superior biomechanical correction, the short segment group saw what the authors called a progressive loss of radiographic correction. Basically, they didn't fix the deformity, they just fixed the symptomatic level.
And for this specific patient population, that might be okay. The authors argue that in patients with ADS who have predominant radicular pain or neurogenic claudication, and not severe low back pain from sagittal or coronal imbalance, the deformity itself might not be the primary target.
It's about tailored surgery. They emphasize that SNRB is the key to the strategy. It clarifies the responsible segments and reduces the number of surgical levels. In their words, it accurately pinpoints single-segment targets.
Let's talk about the complications for a moment. Did the study see a difference there?
Interestingly, there were no significant differences in postoperative complications between the groups, so it wasn't necessarily safer in the sense of avoiding immediate surgical complications, but it was certainly more efficient and led to fewer long-term revisions.
For our residents listening, let's summarize the surgical indications the authors propose for this limited approach. If you're in clinic, who is the candidate for a single-segment PLIF with SNRB?
Based on the paper, it's a patient with symptomatic ADS who has 1. Low back and leg pain that's refractory to conservative treatment, 2. Lumbar spinal stenosis or radiculopathy with neurological deficits, 3. A Cobb angle greater than 10 degrees, but, and this is the big but, 4. No severe sagittal imbalance. You're looking for that SVA under 50 millimeters and PILL under 10 degrees.
It's a shift in philosophy. Instead of saying, you have scoliosis, I must straighten your spine, we are saying, you have scoliosis and a pinched nerve. I will fix the pinched nerve and stabilize that specific spot.
And the study concludes that this approach can mitigate hospital length of stay and revision surgery rates without compromising the midterm clinical efficacy. They're basically saying that in appropriately selected patients, we don't need to chase the X-ray, we need to chase the symptoms.
I think this study provides a very strong argument for the diagnostic SNRB. It's not just a therapeutic injection, it's a surgical planning tool. If the block works, it gives the surgeon the confidence to stop at one level.
One thing the authors noted was that long-term follow-up studies in lumbar stenosis cohorts, even up to 48 months, have shown sustained clinical improvement with short-segment fusions, even if the radiographic deformity slowly creeps back. It seems that clinical benefit outlasts the radiographic perfection.
It's a great reminder that we treat patients, not images. This paper, Single-Segment Spinal Decompression and Fusion with Selective Nerve Root Block in Adult Degenerative Scoliosis, really challenges the all-or-nothing approach to deformity.
Definitely. It's a retrospective study, of course, so we have to keep that in mind. But the results are quite compelling for the ADS population.
Well, that's all the time we have for today. To our residents and colleagues, remember, the goal is complete decompression of neural elements while simultaneously restoring equilibrium. But the path to that goal might be shorter than you think if you use the right diagnostic tools.
Thanks for joining us on the Neurosurgery Hub podcast. We'll see you next time.
Take care, everyone.